Bismillahirrahmanirrahim. Hello everybody. So a 32-year-old woman gravida 3 para 2 a 38 week of gestation come to the hospital with labor contraction. The the patient prenatal course was normal. Her second pregnancy required a cesarean delivery for breech presentation with 39-week gestation. So first of all, we will highlight that this patient had previous cesarean delivery for breech presentation at 39 week of gestation. Current blood pressure is 100 by 60 mm of Hg, pulse is 115 per minute, and respiration at 26 per minute. Pelvic examination showed the cervix 6 cm dilated and 60% effaced with the fetal head at zero station. I will also highlight this. Uterine contractions are regular and occur every 4 minutes, and fetal heart rate tracing is normal. The patient is admitted to the labor and delivery unit for expectant management and decline epidural anesthesia. 2 hours later, she suddenly appears restless and has intense lower abdominal pain. Pelvic examination shows moderate vaginal bleeding, and the cervix is 6 cm dilated with 60% effaced with the fetal head at -3 station. Fetal heart rate monitoring showed tachycardia and recurrent variable deceleration. Which of the following is the most likely diagnosis? Choice A, chorioamnionitis. Choice B, fetal nuchal cord. Choice C, normal labor. Choice D, placental abruption. Choice E, uterine rupture. Choice F, vasa previa. So first of all, I will highlight it here with the important point here. Previously, this patient had cesarean delivery. Cesarean delivery for breech presentation. This is the first. The second one is that during the first visit, the fetal head is at zero station. Fetal head is at zero station. I will explain to you that what the fetal head station mean. Number 3. That 2 hours later, the female experiences sudden. Patient has intense lower abdominal pain. Intense lower abdominal pain. Number 4. The fetal head protected mean the fetal head goes to at -3 station, and fetal experienced tachycardia. Fetal tachycardia. I will show that what the station mean after knowing that what the station mean, and based on these 5 hints we will easily know that what is the diagnosis of this question. So first of all, this is the fetal head station mean. So from here, this is the highlighted pointed here. This is the highlighted point. That the ischial spine mid between the ischial spine. This is the ischial spine. The highlighted line here, that at this when the fetus head is present at this point, then we can call as that the fetal head is at zero station. Above from the ischial spine is known as -1, -2, and -3, and below from the ischial spine is known as +1, +2, and +3. So first, when this patient arrived to us, the fetal head was present at zero station, but 2 hours later she experienced intense lower abdominal pain, and the fetal head was protected back to -3 station. So based on these based on these 5 hint and the protection of fetal head back to -3 station, the diagnosis of this question is uterine rupture. Why uterine rupture? Because uterine rupture typically occur in patient with pre-uterine surgery, as I highlighted here that this patient has previously cesarean delivery. This patient has a uterine rupture at the scar of her prior cesarean delivery. Uterine rupture often present with focal intense abdominal pain, hyperventilation, agitation, and tachycardia are signs of Intermittent rupture of intermittent rupture and bleeding may be vaginal and are intra-abdominal, as in this patient. The presenting fetal part may retract, loss of fetal station, as I explained to you that first the fetal head was at 0 station and then it retracted to -3, which is pathognomic of rupture. Fetal limb may be palpable on abdominal examination, and fetal heart rate tracing are usually abnormal. For example, fetal tachycardia, etc. I will also show that how the uterine rupture look like. So this is the uterine rupture. As we already see here, that this is the previous scar from the previous cesarean delivery. So at this previous scar, the uterus rupture, and we can on abdominal examination we can palpate the fetal part, as we can see here that the fetus hand is present here. So we can on abdominal examination we can palpate the fetal hand or any part of the body. So come to the choice A. Why choice A? Choice A is incorrect. Chorioamnionitis. Chorioamnionitis is an intra-amniotic infection that commonly causes fetal tachycardia. Its most diagnostic distinguishing feature is intrapartum maternal fever, which this patient does not have. Choice B, fetal nuchal cord. So a nuchal cord, a loop of umbilical cord around the fetal neck. Nuchal cord are usually clinically insignificant but can cause fetal heart rate tracing abnormality during labor, but not significantly pain or bleeding. Choice C, normal labor. So normal labor typically present with the fetal head should descend in the pelvis, but this patient has a loss of fetal station concerning for rupture. Choice D, sorry, this one is incorrect. Choice C is incorrect. Choice D is also incorrect. Placental abruption. So placental abruption is the premature separation of the placenta from the uterus. It typically presents with acute vaginal bleeding, a distended uterus, and abdominal pain, but no loss of fetal station. Choice F, vasa previa. So vasa previa occur when the placenta blood vessel run in the membrane over the cervix. Vasa previa present with painless vaginal bleeding on membrane rupture in addition to fetal bradycardia. So I will explain again to you that why the choice E is a correct one, uterine rupture, as we already see here from here that this patient has previous cesarean delivery plus fetal heart rate is at 0 station first. After then 2 hours later, the patient has intense abdominal pain with the fetal head retracted back to the -3 station with fetal tachycardia. So these all signs suggest that this patient has pre-uterine rupture, as we already know that this patient has pre-cesarean delivery. So previous scar, based on that previous scar, this patient has now uterine rupture. Thank you.